Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to Taskforce TV. I'm recording this today on the land of the Boonwurrung people, and I pay my respects to their elders, past, present and emerging. Today, we're taking a look at the drug treatment options for people with COVID-19, and I'm joined by two of the most in-demand figures at the Taskforce, co-chairs of our disease-modifying treatments and chemoprophylaxis panel, Bridget Barber and Josh Davis. Associate Professor Bridget Barber is an infectious diseases physician at the Royal Brisbane and Women's Hospital. She's team head for the clinical malaria group at the QIMR Berghofer and an associate professor at the Menzies School of Health Research. Professor Josh Davis is an infectious diseases physician at the John Hunter Hospital, professor in the School of Medicine and Public Health at the University of Newcastle, and a senior research fellow at the Menzies School of Health Research, as well as being an adjunct associate professor at the Doherty Institute at the University of Melbourne. So as you can imagine, they're both incredibly busy and we're really grateful for their time today. Josh and Bridget, we wanted to start off by asking a broad question really, which is, given your experience of 2 years now on the COVID task force, what do you think are the key messages for the guidelines in terms of caring for people with COVID-19? Bridget, do you want to kick us off?
Thanks, Tari, and thank you for the invitation to be here today. Look, I think after 2 years on the task force, one of the key messages is that things change so quickly. And any recommendations we make 1 week might be out of date next week. So I guess anyone listening to anything we're saying today needs to be aware that they need to be constantly checking with whether what we're saying is still current. And I guess that's really the main reason why we have these living guidelines, is so that we can be constantly updating them. So I think that's a really important point. In terms of the actual recommendations, I think one of the key messages at the moment is that, particularly now that we've got high vaccination rates, the very large majority of patients who develop COVID will have very mild disease. But it's very important for clinicians to be aware, and for people in the community to be aware, that there are some patients who are at much greater risk of developing severe disease, and that there are specific treatments available for those patients. So I think it's important that people have an awareness of that, so that if patients who are at more risk develop COVID, then they can seek help from their treating clinicians if required.
Josh, anything to add from you in terms of key messages from the COVID guidelines?
Look, I think I'd expand one thing Bridget mentioned, which is that things change rapidly and the National Taskforce guidelines are kept up to date. We're all exposed to a flood of guidelines and information about COVID at various levels, so national, state and local health district, and maybe even your department within the hospital. And what tends to happen is that when we make a change to a recommendation at the National Task Force, it filters down through all those levels, and that takes weeks or sometimes months. So where I work in New South Wales, quite often the New South Wales state guidelines have not yet been updated, even though we've made a change a week ago. So the key message to me is that the most up-to-date guidelines are the National Task Force guidelines, and that's what people should look at in combination with their local guidelines.
It feels, Josh, like the hot topic for the last couple of months has been the new treatments for mild COVID. We've spent most of the time up until now talking about treatments for the severe end of disease, but now there seems to be a suite of new drugs that can be considered for patients who've got mild COVID. Could you give us a few reflections on those treatments and who they might be appropriate for and not?
The two major treatments that are oral, that are for mild COVID. One of those is nirmatrelvir/ritonavir. The brand name's Paxlovid. And forgive me if I just use the brand name and say Paxlovid because it's a lot easier. And the other one's molnupiravir. Now, both of those are approved and available in Australia for use in mild COVID, although molnupiravir is easier to get for GPs because it's on the PBS. So they can just write a script and the patient gets it from a commercial pharmacy, whereas Paxlovid at the moment is not yet on the PBS and still needs to be sourced through the National Medical Stockpile via there's different mechanisms in each state, but can be prescribed, at least in New South Wales, by primary care. I guess the key messages are not everybody needs these medications or will benefit from them. It's only those really that are at increased risk of severe disease. And one thing that people often get confused about, who is that? It's not just that they have to have risk factors for severe disease, which we might talk about a bit more later what they are, things like diabetes and age. They also have to be early in their disease course, so within 5 days of symptom onset, have symptoms of disease. So we're not interested in asymptomatic COVID infection. Be not immune or not fully immune to COVID. So that means they're not vaccinated, or they're partially vaccinated, or they're not able to respond to a vaccine. So they have to have all of those things to be eligible for these medications.
Bridget, I'm interested in your reflections. What are clinicians asking about these treatments? What are the questions that people want to know the answers to in terms of the treatments for mild COVID?
So I might just start by adding to what Josh has said already, in that there's, in addition to the oral medications, there are also other medications that can be given in health facilities. So they include the monoclonal antibody sotrovimab, which is given as a single intravenous infusion. So it's not as easy to give as the oral medications, but can still be arranged for patients in the community. And then there's an antiviral medication, remdesivir, which also needs to be given intravenously, and that's given for 3 days. So again, it's not as convenient for patients in the community. But some of these agents might be useful for patients who are particularly high risk and might be admitted to hospital for monitoring, or even just for other reasons. So those agents may be something that can be given to those patients. One of the things I'm being asked about at the moment is how the new Omicron variant affects what we recommend. So the Omicron BA2 variant is very rapidly becoming the dominant variant in Australia. And there are concerns about whether some of these agents may be slightly less efficacious against the Omicron BA2 variant, and sotrovimab is a good example. And there is some preliminary data to suggest that there is a possibility that sotrovimab may not be as effective against that variant. So that's certainly something I'm being asked about at the moment, and that's clearly an area that we need to watch very closely.
And coming back to Josh's point that the guidelines are very frequently updated, we've actually just published the recommendations around Evusheld too, which is another one of the MABs in this space. Josh, what questions are you being asked around the use of these drugs?
So look, they're mostly around, is this patient eligible for one of these drugs? And it's mostly been sotrovimab until recently, because the access route to get sotrovimab is you have to ring your local hospital, usually infectious diseases physician. In some places it's respiratory. So I'm getting a lot of questions about that. And then on the oral agents, it's more around, is this particular patient eligible? How do I get hold of it? And then maybe just to expand on the Omicron BA2 issue that Bridget was talking about, with the exception of the monoclonal antibodies, we've got no reason to believe mechanistically that these oral antivirals are less likely to work against Omicron. However, we don't actually know what the relative benefit is in Omicron, because all the clinical trials were done in the time of Delta and previously. And as people probably know, Delta causes more severe disease. It has a much higher risk of causing hospital admission or death. And the whole point of these medications is to reduce your risk of hospital admission or death. So we think they probably do reduce your risk of hospital admission or death with Omicron, but the number needed to treat is likely to be a lot higher for Omicron than it was in the trials for Delta. We don't know that. We assume that that's the case, though.
I want to come back to your point earlier too, Josh, around what patients are likely to meet the criteria for prescription of these drugs. The question I want to ask is, what does a classic patient who would be appropriate for these drugs look like? But I suspect there's not one patient type that fits the bill. What kinds of things should clinicians be looking for that might indicate that a patient is likely to benefit from these kinds of drugs?
Well, firstly, I guess this could be a plug for the new tools that the Taskforce has just released or is about to release, that help really guide clinicians through the flowchart of logical decision points. And from that will indicate whether for your particular patient these treatments are appropriate. So it will look at age, vaccination status, comorbidities, etc. The first thing I usually ask is, are they vaccinated or not? Because if patients are completely unvaccinated, which there are still people like that out there, then they're definitely higher risk of severe disease. But that's not enough on its own. They also need to have meet the age and other risk factor criteria and be in early disease. So a typical patient, thinking of ones I've discussed with treating doctors recently, would be unvaccinated people in the community who are elderly or have diabetes or obesity, for example, and have early COVID. There's still quite a number of people like that. The other kind of group of patients, more from a sort of hospital angle that we're getting a lot of questions about, is immunosuppressed people. So at my hospital, for example, we have a renal transplant unit. So quite often, probably at least once a week, we get asked about a renal transplant patient with COVID, and can we give them sotrovimab? And usually the answer is yes, if they're early within their infection.
Thanks, that's really helpful. Bridget, any thoughts from you about the kinds of patients that are likely to benefit from these?
I thought I might just expand, Tari, on the last point that Josh made about patients who are immunosuppressed, because I think this is a really difficult area, particularly for those of us who do work in hospitals and see these patients and get asked about these patients commonly. And one of the reasons it's difficult is because COVID doesn't behave the same way in these patients as it does in patients who are not immunosuppressed. So the viremia can persist for a longer period of time, and the progression to severe disease can sometimes occur later in these patients than it does in other patients. So our guidelines are based on the clinical trials, and the clinical trials generally didn't include many patients who were severely immunosuppressed. So I think that's something really for clinicians and for us to keep in mind, is that we don't, although we recommend that these treatments be given very early in the course of illness, so generally within 5 days or perhaps 7 days, we don't really know whether that needs to be the case in these very immunosuppressed patients. So that's something that we just really don't have adequate data for.
That's a great segue into my next question, which is around the things that we still don't know. So in the last 2 years, we've learned a lot about COVID, but there are still big areas where we don't know important things. Bridget, what do you think are the most important unknowns in terms of caring for people with?
Well, I think we've covered a couple already. The presentation of disease and the effect of these agents in the immunosuppressed patients, the timing. We also don't know about whether any of these agents should be given together. So we generally recommend that only one of these available agents be given, so that you would either give someone sotrovimab or you would give them an antiviral, but you wouldn't necessarily give both. And that's just because we don't have any data to suggest that we should be giving both. But we also don't have data to say that we shouldn't be giving both. And again, in these very high-risk patients, we just don't know. And maybe these high-risk patients would potentially benefit from a monoclonal antibody and an antiviral, but that's something we don't know. Josh has already talked about the fact that the trials are mostly done during the time of the Delta variant. So that's another important unknown, and new variants will continue to emerge. So that is probably always going to be the case. By the time we have data for Omicron, we'll have a new variant. So we're always going to be a step behind. And perhaps the final point to make is that the trials were generally done in unvaccinated patients. So in most of the trials, even for people who had one vaccination, that they were also excluded. So as well as the number needed to treat being higher for the Omicron variant, it's also higher for patients who have had one or perhaps two doses of the vaccine.
Thank you, that's helpful. Josh, Any other thoughts about unknowns?
I guess what, as Bridget says, we have covered pretty much all of them. The one I'd add is the comparative effectiveness of these drugs. So each of them has had a clinical trial where they've been compared with placebo or no treatment. And so we infer from those trials that, for example, the relative benefit of Paxlovid and sotrovimab is a lot higher than the benefit of molnupiravir. But they've never been directly compared with each other within a clinical trial as a comparative effectiveness study. And hopefully with increased availability of these drugs that will happen, but we don't know that either.
I mentioned before, it's 2 years since we started talking about COVID. And I'm interested in your thoughts about, ideally, of course, in 2 years, we won't still be here talking about COVID, but looking forward, what do you think what one thing would you change that would improve the care of people with COVID as we look into that future period? Josh?
I think for me, it is around vaccination. So the ideal vaccination would be not dependent on strain or genotype or variant. It would be work across coronaviruses, or at least across SARS-CoV-2, and will give you long-lasting immunity. So it wouldn't matter if new variants emerge. Once people are vaccinated, they're protected against disease. There are vaccines like that in development, in quite advanced development. It's remains to be seen how effective they are. But if that sort of holy grail vaccine comes in, then a lot of the rest of our work becomes irrelevant.
It's always good to put yourself out of business in this kind of area, isn't it? Bridget, your thoughts about what one thing would be the game changer in terms of improving care?
Tari, I would absolutely agree with Josh. I don't think that question can be answered any other way than vaccination. And, we need everyone to be vaccinated. 90% is not good enough. We just need everyone to be vaccinated and fully vaccinated. At the moment, we're recommending a third shot as a booster, but that will presumably change in time as well. So we just need to ensure that everyone is keeping up to date with their vaccinations.
We mentioned earlier that there are some challenges with using some of these drugs. Paxlovid, for example, has a range of interactions with other drugs and so on. Any reflections on what that means in a clinical context, Josh?
Yeah, so I think particularly for Paxlovid, because of the ritonavir component, there are a lot of drug interactions. And it's really important to check those thoroughly before starting a patient on that drug. And just as a cautionary tale, last week we had a patient on our COVID Care in the Home program who had early COVID. She had risk factors and was unvaccinated. And she was started on Paxlovid on day one of meeting her, which is day 3 of the illness. That was all fine. The next day she called our nurses saying, I feel really bad, faint. Every time I stand up, I'm about to faint, etc. And as it turned out, she was on a blood pressure medication called lercanidipine, a calcium channel blocker, which interacts with Paxlovid so that her blood level of lercanidipine was a lot higher. And the GP who had prescribed the Paxlovid, when we raised this with them, said, I didn't see that. That wasn't on the kind of top line listing that they looked at. But if they'd gone to the University of Liverpool website or app, that this would have come up as a kind of red light drug interaction. So I guess that's just to kind of a plea to really check those drug interactions carefully.
Thanks, Josh. That's really important. I know that we've tried to summarise those drug interactions in a useful way, but it just goes for pages and pages. So important to check. Thank you both very much. I hope you've all enjoyed today's show. If you've got questions that you'd like answered by people like Bridget and Josh or others, please send them through via our website or our social media channels. And please share this with your clinical colleagues and look out for our next episode of Taskforce TV. Thanks very much.